Welcome everyone, welcome to the Civil Service Data Challenge semi-final. We're all really excited to have you here today.
Excited to be here, and our team, we are very passionate about helping our NHS nurses and doctors so that they can give the best possible care to our patients. And today we are asking for your support to help us realizing a tool that we have developed, a tool which we believe will really transform the lives of our district nurses, with even more potential beyond the health services. So I'm sure we all have heard about how much pressure the NHS is under. In the case of district nurses, it cost the NHS more than £200 million in missed appointments and cancellations last year. That is the equivalent to salary for an additional 2,300 time GPs. Now imagine yourself in the shoes of our district nurse, Jenny, for the day. Jenny's job involved going out to patients' home and community, providing the care that they need so that they don't have to visit the hospital, and thereby reducing the number of hospital admission and hospital stays. Jenny's daily caseload has increased dramatically over the years. She has to travel long distances to visit patients across multiple trust areas. In fact, it has been estimated that our district nurses use up to 500,000 tons of CO2 in traveling to patients. That's equivalent to annual emissions of the whole of Greenland. Now, the day-to-day scheduling of Jenny's activities is still being done manually using spreadsheet and depending on the expertise of her caseload manager. If an appointment was to run overtime or there's a delay or cancellation, Jenny will have to contact her manager and wait for her schedule to be recalculated again manually. This is very cumbersome, time-consuming, stressful, and obviously costing the NHS a lot of money. So it's obvious that we need a better tool, a more efficient tool for our district nurses to spend less time traveling to patient, less time scheduling and route planning. And this is what we're hoping to do with our tool, our open source geospatial planning tool. I'll now hand over to Paul to explain how we envision this tool can be used by our district nurses.
So imagine Jenny waiting to receive her list of patients for visiting around Cambridge for today. And this is something that her logistics hub do on a daily basis. They don't have access to our proof of concept route optimizer tool here though. In the red, you see the town Cambridge, and below, the name, the address, the town displayed. There's also the ability to enter a different start address should you need to. And on the left, the ability to upload your own data as well. Once you click run, very quickly returned is a map with the route optimized, and this minimizes traveling distance. And below, for each leg, you have the from, the to, and to the right of that, you have the distance traveled, the walking time, bicycle time, hard-coded car, peak times, and off-peak times. This type of app is a game changer for the NHS. District nurses from our research and their logistics teams don't have access to this type of functionality. But the private sector do. Domiciliary care company Sera already uses travel optimization algorithms like this. Their staff are able to visit 2 extra patients a day, and they have the ability to potentially earn 30% extra take-home pay. The source for this is Rachel Sylvester, the Times Health correspondent in the NHS at 75 last year in July. We would love to bring this type of optimization to the NHS because the additional cost savings could be fuel costs are minimised, but additionally, environmental costs can be minimised as well. Further user feedback we've encountered is the need to reduce appointment cancellations. Our second page in our proof of concept shows the ability to take an appointment van out into the country, which is something we've been asked for in different hospital trusts, and locate it close to patients with the aim of reducing patient cancellations. Lastly, post doing a geospatial presentation at NHS PICOM, different areas of the NHS got in touch and asked about solutions that we could provide. And this is a lo-fi solution that the COVID team asked, with the aim of where to locate a vaccination hub. What you see here is Leicester railway station with a 1-mile radius, located with population scanned underneath and the walking time hard-coded. This is the type of geospatial solution that retailers like McDonald's and Aldi use on a regular basis. They employ commercial providers like Targomo, who also add public transport means. They add competitors and substitutes into this. But that type of commercial operation is very expensive, and it can cost between £50,000 and £250,000 per contract per ICB. That adds up to between £10 and £50 million a year where every trust to have a contract. Let me hand over to Kike.
So why our geospatial solution? Our planning tool will allow Jenny to execute optimal location searches, route optimization, and calculate multiple shortest routes. This would mean less time traveling, more time spent with patients, more appointments scheduled per day with less administrative stress, and less chances of cancelling appointments. It would also improve our well-being by reducing the level of uncertainty with scheduling visits. Based on the data provided by a private care home provider, their AI engine tool for scheduling appointments led to a 13% decrease in carers' traveling time and distance, which also meant that 9% less staff could deliver the same level of care and service. Applying the reduction in traveling time could also hugely contribute to our environmental sustainability goals. With the projected 13% reduction in traveling time, it could reduce up to 65,000 tons of CO2 emissions. And last but not the least, because this tool has been developed by staff working within the NHS, it means it already meets the governance standards for NHS data. And it could help build the government's technological capacity and also save on maintenance and onboarding costs. And I'll pass you over to Paul.
Thank you. So what are our challenges to implementation here? Everything you've seen so far is a proof of concept tool that was generated from users coming to us and telling us what they needed. 6 different areas of the NHS reached out, and we built this proof of concept tool. And since then, we've gone back to them for further feedback. The consistent feedback is really in 2 areas, and there may be a third area as well. The first is real-time highways data. Can we integrate this into the tool, which will give you peak times, off-peak times, merged together to give you the route around Cambridge, like I showed you, but with a real rather than fixed speed time. And this is something that's been consistently asked. That can also apply to all of the pages. The second is the gap analysis we have from those users. Could we allow them to upload different sets of data? For example, Department of Health wants to analyse social care homes and where their catchment areas merge with hospitals in order to identify where hospitals can discharge people to. We don't have the ability to do that yet, but going from proof of concept to MVP would allow us to do that. Lastly, this is an IG solution because areas of the NHS that got in touch told us that solutions that are out there were either externally server-based or they weren't able to use them because the solutions didn't exist. This only uses geocoding at a road level, in which case no patient data is disclosed.
Thank you. In the near future, our vision is to take our product from proof of concept to MVP. And to establish this, we have set up a roadmap. We are looking to include live traffic data through the OS highway data that Paul just mentioned, and that can be set up through an API feed, which is free of cost for public sector. We're also looking to improve the users' input into the tool. So currently, they can select pre-existing data that is being fed into the tool through locations and postcodes, but we want them to be able to, for example, input the name of a care home to take a community care van to. Our code is also adaptable and reproducible, and so there is a remit that can be applied within the wider public sector. And there's so much potential that can be harnessed by a tool that is being built within the public sector. So some of the examples of where this can be used is in Ministry of Justice to access the location of parole review sites, which is very sensitive in nature and actually requires a secure, lightweight app such as ours. Some other examples include adding population metrics onto the tool to identify for DEFRA where new recycling centers can be established and for DWP where new job centers can be established. Another development that we're looking to make on the tool is to convert it into an installer-style product, because currently it's a code base, and we would like to overcome the coding barrier and widen the remit to analysts across the government. It's often acknowledged that there is no shortage of innovation within the NHS, but rather a lack of uptake. And so we are designing our process to ensure that we are taking feedback from our users right from the start and feeding that into the alpha stage and building whatever is required for them and making the tool fit for purpose. Through this graduated and planned approach, we are hoping to take our tool, Geospatial tool that you have seen just now, from proof of concept to MVP, to beta, and ultimately test with users and save the government a lot of funds and add to the suite of tools that the analysts currently use. Thank you for your time and the opportunity to present. Over to you for questions.
Thank you very much. Who'd like to kick off? Sue?
Brilliant. Thank you so much for that presentation. There's clearly A lot of passion from you as a team around this issue, and it's great to hear where you are in the process. I guess the question for me is related to those last bits of the presentation. The case that you've presented around the district nurses feels like really tangible and compelling. I guess the danger for me is when you start to get lots more user feedback, and there's a potential for it to become a bit too diverse and maybe distracted from the original concept. So how do you envisage handling that? So having that clear purpose, but also having a mind on that reusability and scalability?
Sure. At the moment we have a code base and it's designed as 3 pages within a web app. That can be cloned, and the idea being that MOJ will have their own version and they could use the basic underlying algorithms just as a district nurse would, and that would not change unless they want to alter the code. There is that ability for them to have 4, 5, 6, 10, 13 pages for their own version should they want to. The district nurse version, the routing optimizer, won't change at all, as the algorithms that underlie and underpin the 2 pages of the code are exactly the same and will be used and can be adapted. So our aim is that we can keep this as a code base and have it adaptable for each government department as well as district nurses. We could also allow it to be an installer style product for analysis that can be fixed. And by that we open it up to not just coders but other users as well.
So why wouldn't you just use Google Maps and then add on to that? What's this tool doing that goes above and beyond that?
Google Maps only allows you to search for either one, or I think if you can put a second stop within the actual location. And I believe that may be how district nurses are operating now when they get their list of where to go. But the total list is a route optimization problem for which there isn't a solution out there. There are commercial solutions, but there's nothing within the NHS or district nurse area that does that. The difference would be if you want to go from A to B to C to D, and that may not be the optimal route that you have just by doing them one at a time with Google Maps. It can actually save you a lot of time, allow you to spend more time with patients. And we know the evidence is there because private sector are doing this, Syria are doing this, and they have optimization algorithms that work. So why can't we do it for the NHS?
Hello, John Quinn from the NHS. So my question is around that real-time highway data. So again, building on the point about available resources, what blockers have you found to achieving that integration, and how are you thinking of managing them?
We have started doing some research on how this can be set up. We currently have some projects within the NHS where the API has been already established and they are able to utilize this data. So currently, what we don't have is live traffic data. So the route is optimized based on the existing distances that have been fed into the tool. So once we have the live traffic data from OS highways, there is a possibility to make this more real time. And if there is a cancellation, for example, it wouldn't take you loads of time to recalculate this distance, but the tool does it in a click of a button.
Can I jump in with, I guess, a bit of a practical question? If you do get through to the finals in July, how can we expect the idea to evolve? You set out a clear plan for the MVP there. I'm just interested in what the next steps would be.
Yeah. So within the next 3 months, until we see you in July, we will continue with the roadmap that Divya has outlined. So in particular, we plan to have focus groups of district nurses and people from the logistics teams from different areas within the NHS, and work with them, talking to them about the tool and understanding their workflow and seeing where the tool can come into their workflow, and also get their feedback on what are the kind of user interface that they would like, and we may be able to change some of the modalities in the tools according to the feedback. And at the same time, we're hoping to also have meetings set up with some of the organizations that have expressed interest in the tool. So we're hoping to have those meetings and again, talk to them about the tool and get their feedback in particular about what are their requirements to implement such a tool into their organizations. What are the things that the information governance and things like that that they require. And yeah, so that will help with the implementation process down the track.
As you were talking, it's like, yes, this is brilliant. Why haven't we done it already? And I'm sure that's, so I've come from the MOJ where if you're trying to implement something in one prison, that's fine, but then you've got to go to all the other prisons across country and things work differently, et cetera, et cetera. Is that a challenge? I'm assuming in the NHS, and therefore, what do you, I guess, help me to understand the kind of energy and complexity of taking something like this and rolling it out across the NHS?
Best way I can describe the NHS is like a shoal of fish, rather than one organisation that you approach. So PICOM, NHS PICOM, the conference has been instrumental in getting feedback for different areas of the NHS in order to exchange code and to implement it. I'm on the board of NHS PICOM and work at NHS England. From working with different trusts around the NHS, we understand what their issues are. And generally, within certain trusts, or within most hospitals, most of the logistics teams have similar issues. They're reproducible all across. So our feedback has been to work with different analysts to get feedback, but also to work with different areas of different trusts and GP practices, which is part of my job that I do for working with PhD researchers when we place them with different trusts. So this is dovetailed nicely with my current day job to get user feedback for something that we are trying to build in the data science area in order to give them what they want. And the way we look at it is if this is low-hanging fruit, why can't we do this, save money, and get commercial contractors to do the things we can't do?
Brilliant. So I'm Aydin from HMRC, so that was brilliant, thank you. And made me want to use one of those for after-school pickups, play dates, all sorts of things. Just kind of building on the, why don't you use something out of the box, in a sense. So I got, and I'm paraphrasing, that it can be quite expensive. There's tools out there that optimize. Can you just delve into that a little bit more? Have you looked at that and realised that the cost is prohibitive? Why wouldn't you just take a product off the shelf and use that? So
we are aware that there are lots of competitors out there in the commercial space. However, they cost a lot. This costs between £50,000 to £250,000 per year on contract. But just to say that this tool was developed based on gap analysis. So there's been several conversations with NHS analysts stating the need for a one-size-fits-all tool. So the other tools that are out there in the commercial space, they are not able to perform all the functions in terms of optimizing travel. So we have Tagomo, for example, which does site scoring. We have Shape Atlas, which performs a number of functions, but it doesn't do route optimization. But the good thing about this tool is that the tool has the potential to be able to perform all the functions to optimize travel, whilst adhering to the information governance boundaries. So we've done our research, and we know that this is something that is needed, and especially in terms of the cost. It would definitely save a lot of money. And so we are hoping that with your support and your resources, we will be able to develop something and tailor it specifically to the users.
Any other questions for the team? Really great job, team. Thank you very much. Well done.
I love the shoulder fish analogy as well for NHS. I'll use that.